Okay, good morning, and welcome to the Clinical Neurosciences Grand Rounds for today. We are pleased to welcome our speaker today, Dr. Erik St. Louis. Dr. St. Louis is a professor of neurology and a professor of medicine at Mayo Clinic College of Medicine in Rochester, Minnesota. Also director for research and scholarship at the Wisconsin arm of the Mayo Clinic Health System. Dr. St. Louis received his medical degree at the Medical College of Wisconsin and residency in internal medicine and for his preliminary and neurology at Mayo Clinic Rochester, and then did a fellowship in epilepsy at Mayo and a Master of Science at University of Iowa's College of Public Health. His research interests are sleep, neurodegeneration, cognition, and epilepsy, and he is widely funded. He's authored over 200 articles, 3 books, and 50 book chapters, and he is representative of an intersection of several subspecialties, as you'll see today. The interaction in this case of ethics, pathobiology, and clinical neurology for his talk, Not So Isolated RBD, Prodromal Synucleinopathy and Implications for Diagnosis and Prognosis in REM Sleep Behavior Disorder. Thank you for coming, and welcome, Dr. St. Louis.
Well, thank you very much, Perry. So I'd like to thank, Dr. Perry Richardson, Dr. Mohammed Kubaisi, and Ms. Crystal Woods for the kind invitation and setting up the logistics today of the talk. I always find it a marvel that we can connect this way with our colleagues on the coast and across the world still, even though we've been at it now for a few years. So it's a real honor to be with you today. I guess I'd like to also ask, is my audio coming through okay? Does it seem good?
It's fine.
Okay, great, glad to hear that. Okay, so without further ado, I'll dive in. You'd wonder with reading the title if we're ever going to get past the title slide. It's kind of a long one, but it's meant to kind of be a riff or a slight joke on the issue of the rebranding or renaming of REM sleep behavior disorder from an idiopathic disorder several years ago to isolated. The concept being that it's felt in most adults, perhaps particularly older adults, from evidence I'll show you, that this is an at-risk disease or disorder for having an underlying neurodegenerative cause for the disease. And in most cases, that proves to be an alpha-synucleinopathy neurodegenerative disorder, namely the Lewy body diseases or multiple system atrophy in some cases. So we'll show some of the rich connections and associations between RBD and that in fact, many patients already have an incipient prodromal state of neurodegeneration, and that would be the not so isolated part of the condition. We'll also allude to a few other causes to consider in the differential diagnosis when you're seeing these patients. In terms of disclosures, I have the sources of grant support from federal and foundation sources listed above, but there are no other consultancies or dirty laundry to air today. And I'll allude very briefly just to the 2 chief symptomatic therapies currently for REM sleep behavior disorder without getting a lot into others. This remains an area where there's a paucity of evidence basis for practice, but melatonin and clonazepam are both off-label for the treatment of RBD, and in fact, there's no FDA-indicated therapy or real good body of evidence for either in the current state. I'll also allude to a device we've been working with for a few years now, the Sleep Profiler, which is one of these headband-type EEG devices for home sleep testing, and work we're doing to try to validate this as a home sleep test for REM sleep behavior disorder and other conditions. So the specific learning objectives today will be to hopefully enable you to understand the current evidence for the strong association between not so isolated RBD and the synucleinopathies, to appreciate the prognostic implications of various biomarkers with testing in older adult patients that really tend to connote a greater risk state for phenoconverting or converting from isolated RBD into a manifest disease, such as Parkinson's disease or dementia. We'll consider some of the alternative causes and mimics of RBD that should be part of the differential diagnosis for this condition. And then we'll try to conclude with a still thorny area, one that I think remains difficult in the current state, that is trying to offer prognostic counseling for the newly diagnosed isolated RBD patient in terms of where the disorder may be heading, how at risk may they be. Once patients learn about this connection, they're understandably quite concerned in many cases. But we'll start with some foundational material before moving into the heart of the talk. I wanted to make sure everyone here was familiar with the clinical entity of REM sleep behavior disorder. And while I think most of you are, I think it's likely also a bit of a mixed audience of clinical neurosciences gathered here today. So what I'm going to show you here is a prototypical video from an in-lab polysomnogram of a typical older adult with more violent REM sleep behavior disorder characteristics. And we'll look at that video now. I'm not sure the audio is going to come across the Zoom. So I'm going to hold this up to my speaker here. You can hear him rustling around the bed sheets and some verbalization or vocalization. You can see he's really having a lot of pretty large-scale torso movements. Some arm flailing movements. His eyes are closed, contrary to most nocturnal or wake, for that matter, seizures. And he uttered a little profanity-laced speech, which is uncharacteristic for this individual. And it was a fairly brief episode as well. You could see he aroused right at the end. And this, I think, is the prototypical story. We've understood REM sleep behavior disorder from its outset to largely be a potentially injurious and violent sleep disorder, or with action-filled dreams. Some patients have more of a sports dream. And so the story shown on the left accompanies the scan shown on the right of an older gentleman, 77 years old, initially cognitively normal without any other neurological disease evident. But he had a dream late in the night that he was catching a punt in American football, and he dove to catch the punt in his dream, but in real life dove out of bed and struck his head. And you can see on the right a series of axial CT scans, a large subdural hematoma gathered, particularly on the right, with a little bit of acute blood on the left as well. And this gentleman required a neurosurgical evacuation of his subdural blood clots. So serious injuries can occur. They're rare, but this case really exhibits that kind of more dramatic story. And I would tell you that currently there's a much more heterogeneous and often subtle presentation of this disorder. It's not all violent, obvious sleep disorders. Sometimes the clinical behaviors of this disorder fly below the radar. But in this case, the gentleman had a 5-year course where he progressed from isolated RBD symptoms into dementia with Lewy bodies and required nursing home placement. So that brief paragraph or story tells essentially the whole story writ large of RBD and its connections with the synucleinopathies. Injury does happen in about half of patients. Most are minor injuries. About 11% now is emerging as the figure, so 10 to 12% in various studies are serious injury, like the one I just described to you, either a subdural blood clot from striking the head, or a long bone fracture, rib fractures, perhaps more commonly lacerations requiring suturing in the ear. So that would be the spectrum of many of the serious injuries seen, but thankfully most patients don't have it that bad. We still use symptomatic treatments and counsel patients about bedroom safety, removing weapons from the bedside. It's surprising when you talk to patients how many people sleep with a pistol in their side night table drawer or under their pillow. So you don't want that around where it could be grabbed and fired during the night. If there are any souvenir samurai swords above the bed, we want to remove that from the bedroom environment. Things like thinking about the placement of sharp-cornered furniture, even lowering the bed if there's been a history of frequent falls from bed, are all safety issues to discuss with these patients, in addition to the symptomatic therapies. And dose ranges that we typically use are outlined there: melatonin 3 to 15 milligrams, clonazepam about 0.25 up to 3 milligrams being the typical dosage ranges. Not all patients tolerate these drugs well, so sometimes creative thinking is necessary to try other symptomatic therapies that might work. But as mentioned, when subjected to rigorous evidence basis and testing in the setting of a randomized controlled trial, neither of these agents work particularly robustly. So we're in need of better evidence for symptomatic treatment. So at heart, the isolated REM sleep behavior disorder is now the terminology because of this recognized strong connection with other symptomatic neurologic diseases. But when it presents without obvious concurrent neurodegenerative disease or other underlying causes, it's called isolated RBD these days. And the chief characteristics are twofold. The requirement of some degree of what we may call dream enactment behaviors. These are complex vocal or motor behaviors during REM sleep. They're most often violent and potentially injurious, but not always. We see a spectrum of other behaviors. We've seen some patients exhibit simple behaviors like eating, knitting. Anything you can do while awake essentially can be done during sleep with lost REM atonia control. And that is the other hallmark and the presumed pathophysiologic characteristic of RBD, which is loss of normal REM sleep atonia, also called somewhat awkwardly REM sleep without atonia, or RISWA, as I'll call it for short. And this is really the diagnostic polysomnogram signature seen on patients even intra-ictally, so-called, between their behaviors. And that is a requirement for diagnosis in the current state. So the recent ICSD, the International Classification of Sleep Disorders, that describes taxonomy of our sleep disorders, also specifies that absent a history or obvious REM sleep without atonia, if you record complex vocal or motor behaviors during REM sleep, that is also satisfying for the diagnosis. Now, we've learned a lot about community prevalence of this disorder in the last decade. It hovers around 1.5% to 2%, so this is a common disorder that skews toward being seen in more older populations. Those populations are likely enriched, and some studies hold that about 7 to 9% of older adults aged 70 to 80 and up might have RBD symptoms. There are fewer polysomnographic studies to verify that all of those patients have RBD. If we look at the entity we're now calling isolated REM sleep without atonia, that is just the polysomnogram characteristics of increased muscle activity during REM sleep, but no clinical behaviors accompanying it or recorded. That's even more common. And many studies hold now that that may be as common as even up to a quarter to a third of normal adults without RBD. If you use perhaps more rigorous and higher threshold definitions, however, it hovers around 10 to 13%. Still quite common and much more common than RBD itself. Now, you've heard me allude to this entity of RISWA, REM sleep without atonia, or lost normal REM sleep atonia. I wanted to show you what we're talking about so you at least qualitatively appreciate what that is. These are two 30-second epochs of a polysomnogram. And you can see in the lower pane here, I'll point out the typical manifestations of REM sleep being rapid eye movements, typical EEG pattern of mixed frequency, slower activity, and some faster activity. And additionally, in the EMG channels, the chin and the forelimbs, we can get nice, clean atonic recordings when we record from the individual limbs. And you can see there's barely any muscle activity present at all, maybe some little blips here and there, but nothing that stands out. This would be a normal example of what REM sleep paralysis should look like. When we see a patient, this is an obvious one, okay? Not all are this obvious, but you could see a lot of phasic muscle activity. That's these briefer bursts highlighted by the red arrows. And if you squint a bit and look kind of at the lower voltage elevation under the phasic activity, you'll see a little bit of tonic muscle activity there as well. So phasic and tonic motor activity or muscle activity during REM sleep are what we measure, usually quantitatively for research. And I'll show you some examples of how that can be a valuable biomarker for the disease. But really, at a glance in the clinical polysomnogram lab, in most cases, you can see this differentiating characteristic characteristics stand out from the background. And as mentioned, we see it in not a small number of normal adults without RBD, where it's even a bit more problematic. What do we tell patients about that, if anything? Because it's not really a clinical entity and not as richly tied to neurodegenerative risk at this time. So let's go ahead and dive into the heart of the talk with that foundation. And the whole model underlying this is that isolated REM sleep behavior disorder, or as I've called it, not so isolated RBD, may follow one of three chief trajectories over time, where patients gradually accrue additional symptoms and signs of an underlying neurodegenerative state, which can include cognitive dysfunction, evolving to the phenotypes of mild cognitive impairment or dementia with Lewy bodies. We can see a chiefly motor phenotype with Parkinson's disease, or we can see an autonomic phenotype, which is usually multiple system atrophy, but can be Lewy body disease as well. Some patients don't read the phenotypic classifications of these disorders very well, so they have a mixed phenotype. It can be hard to know exactly what to name them. The convention between a cognitive and motor disorder, at least, has been the 1-year rule, meaning if they present cognitive first before motor or concomitantly with motor deficits within a year, we call that dementia with Lewy bodies. If they present with motor first by 1 year or more, then cognitive disorder, that is Parkinson's disease. But of course, that's arbitrary, and sometimes it's hard to delineate the two. The idea is that over time, these patients accrue additional deficits, and that already at presentation, you can often find subtle signs, soft signs, if you will, of neurological dysfunction. And that really was the metaphor we chose for our large NAPS study, which I'll tell you about. NAPS, always got to have a clever acronym for your study, right? But NAPS stands for North American Prodromal Synucleinopathy Consortium. This is a group of 9 centers aligned on harmonized evaluation of RBD, so we learn more about its natural history to set us up for future neuroprotective trials. But the metaphor chosen for this disorder was that of the iceberg. And it's a big old iceberg like the Titanic, unfortunately, might have seen. You see a little bit of iceberg at the surface. That's the RBD and its clinical manifestations. But submerged under the surface is a covert degree of dysfunction that really signifies the whole disease that is potentially unfolding. And of course, the soft signs are heterogeneous, but often include non-motor deficits. We've learned a lot about non-motor problems in Parkinsonism over the last 20 years, and they're often a harbinger of greater motor dysfunction to come, or sometimes the cognitive phenotype of DLB. And the left side of this slide is showing an older gentleman, again, dreaming of boxing. He's having RBD movements in his sleep with arm flailing and kicking as he acts out his dream. But this patient might be queried or objectively tested for the presence of hyposmia, of constipation, and of postural dizziness or orthostatic hypotension. And a surprising frequency of these patients in our cohort and others, it's been seen between about 70 and 90%, which is really the historical rate of phenoconversion as well. 70 to 90% of patients show some level of additional non-motor dysfunction aside from their sleep disorder before they develop more obvious clinical manifestations. And we could think of this conceptually as what's seen clinically from a spectrum of either asymptomatic initial patients, post-symptomatic with a few symptoms or signs, but nothing great, nothing diagnostic for disease, and then crossing some threshold at some point to develop a manifest disorder. And signs and symptoms are often present at presentation, but not always. We're learning a lot in NAPS that the squeaky clean isolated RBD patient is a rarity. And again, somewhere in the order of about 70% of patients have one or more soft signs at presentation. We've seen evidence for progressive REM sleep atonia loss, so that the amount of REM sleep without atonia accumulates during the disease. And presumably what's going on under the hood is, as painted out by Heiko Brock from a large pathologic study of Parkinson's disease many years ago now, that there's thought to be a usual caudal rostral ascension of perhaps transsynaptic spread of neuropathology, and Lewy body disease characteristically might begin in the brainstem levels where REM sleep atonia control exists, in the pons and the medulla, particularly affecting the subceruleus nucleus and perhaps the magnocellular reticular formation. But as it ascends, it's going to hit the midbrain and hit the substantia nigra, and further ascends, it may ascend to cortex, and Lewy body pathology becoming more disseminated, with a rather sobering rate over time of so-called phenoconversion or development of a manifest neurologic disease. Now, a variety of studies have looked at this everywhere from the community to mostly with longitudinal follow-up sleep center cohorts of patients who present with RBD and later develop accruing disease followed annually over time. So from the community, one of the better studies came from right here in Olmsted County in Minnesota. Brendan Boot and Brad Beauvais years ago showed that in the community, that the hazard ratio for development of incident mild cognitive impairment or Parkinson's disease is about twofold greater in those with RBD symptoms versus those without RBD symptoms. So there's one line of evidence even in the community that this connection exists. In large single center cohorts largely and one large multi-center cohort I'll show you data from, the rate of phenoconversion, that is developing DLB or Parkinson's disease or MSA over time, hovers between 50 and as much as 91%. We have a new paper that I'll show you some data from that I think is quite interesting that suggests one of the largest clinical drivers of this, unsurprisingly, perhaps is age. And that seems to only be the older segment or the older age strata that is most at risk, at least in the short term. So the traditional survival curve, I would say, over the last 15 years of accumulating data looks about like this. This is the largest study to date assembled from our International RBD Study Group, which is a consortium of 24 or more worldwide centers looking at RBD. It's a large cohort of 1,280 patients, and Ron Poshtuma from Montreal led this analysis. But it shows soberingly that the overall annualized risk of conversion from RBD to PD or DLB is about 6% per year. So if you do the math, that accrues quite rapidly, where the 3-year risk would be 18%, at 5 years over 30%, and the 10 to 12-year risk ramps up to 60 to 75% risk range. And if you keep following them, there's even a higher degree of conversion later on. Interestingly, when we looked at all comers of age, and a unique part of this cohort from Mayo was we looked at all women deliberately, because that was a scalable study to do over time since 2008, and looked at their clinical outcomes. So as a clinical cohort of patients seen at our sleep center, we matched them to men at the time of polysomnography, thinking that there might be some difference between the sexes or other clinical characteristics that drove conversion. This paper was published now recently in Neurology. But you can see that the annualized conversion risk rates over a median follow-up of about 6 years is quite different by different age strata. So to walk you through this complex failure curve, here we turn the survival curve on its head. So phenoconversion is plotted up. But you can see the 70-year-old strata is most at risk for developing Parkinsonism or dementia. And all the other strata have a markedly less rate of phenoconversion. In fact, those under 50, the conversion rate is negligible. And the oldest phenoconverter we found in our cohort was a 49.8-year-old man at the time of polysomnographic presentation. And in fact, sex, other factors dropped out entirely as independent predictors of conversion. Age was the entire driver. Using logistic regression, ROC analysis, the single best age for predicting phenoconversion at polysomnogram diagnosis was 67, which is actually almost identical to the mean age of every other cohort. So it does show the power of looking at a younger aged cohort. Our mean age was something more like 58 to 60. So it gives a little fuller picture of what's going on throughout the lifespan. Again, just a little bit of looking at other more univariate factors for prediction. Here, the overall phenoconversion curve is drawn, looks similar to many others, although lower cumulatively because of the younger age cohort. You can see that sex, well, separated initially, men converted a little bit quicker, but you can see the women catch up, so that it finishes in a dead heat by the end. Interestingly, there's been some data to suggest that antidepressant use or psychiatric disease may be a factor predicting earlier presentation and slower conversion. We saw some evidence for that also in our series. And comorbidity has been understudied, and we found that comorbid cerebral vascular disease was an enriching factor for phenoconversion across the sexes. But in fact, once multivariable analysis was done, age was the factor that trumped all. Well, let's move on, and we'll discuss next the objective of appreciating the prognostic implications of various enriching biomarkers. And one thing we lacked in our recent study was clinical biomarkers because it was a clinical cohort. So we did not have other clinical factors beyond age, sex, and antidepressant status. Looking at biofluids for alpha-synuclein pathology is perhaps one of the greatest enriching factors for conversion risk, as we'll see. Looking at various neuroimaging and neurophysiological risk markers also enriches our ability to understand phenoconversion risk on an individual level. So, converging evidence from a variety of different study types and designs has shown that most isolated RBD, at least in older adults, appears to represent a prodromal synucleinopathy. And across various longitudinal cohort studies, we see risk rates of 75 to 90% of patients both phenoconverting, but also interestingly manifesting the movement disorders criteria for prodromal Parkinsonism. The number quoted here comes from a nice large-scale study from Oxford University in UK that when applying MDS criteria for prodromal PD found that 75 to 90% of isolated RBD patients met those criteria. So a lot of soft signs in these patients, largely non-motor markers. If you look at clinical neurodegenerative markers in living patients, such as imaging, cognitive testing, motor testing, or autonomic testing, unsurprisingly, you see a high frequency of various soft sign abnormalities in these patients. Synuclein positivity can now be measured in a variety of peripheral tissues as well as the CSF. And this also may be one of the most powerful lines of evidence for conversion risk. And then autopsy studies have also suggested that patients have alpha-synuclein pathology at the time of death in the setting of RBD. So let's go through these with a little deeper dive one by one. Looking at neurodegenerative and neurophysiologic and neuroimaging biomarkers, a variety of different factors emerge as indicating a weighted higher risk factor or hazard ratio for the development of phenoconversion to a manifest neurodegenerative disorder. And those include abnormal olfaction as measured by an objective smell test, things like the UPSIT or BSIT objective smell tests or sniffing sticks. All these types of modalities of objectively measuring smell stands out as having a hazard ratio of about 2.5-fold greater risk for phenoconversion when there's an abnormality. Abnormal quantitative motor tests, things like the groove pegboard or alternate tap testing of the hands are also quite enriching. Even motor symptoms themselves are enriching for phenoconversion risk. The presence of constipation is a weakly associated factor. Increased REM sleep without atonia, another. And the imaging test of the abnormal dopamine transporter uptake scan, and I'll show you some examples of this, is perhaps the greatest weighted risk factor that when you have a nigrostriatal involvement already at presentation, this is a enriching factor for conversion to disease. So I'm going to go through these different categories of biomarkers in living patients one by one. And we'll start with one that our lab has spent a lot of time trying to unpack, this idea of measuring REM sleep without atonia on the polysomnogram. And today, I hope not to bore you too much with exactly the method used for this, but basically, again, to remind you from our cartoon, we're looking at phasic muscle activity, which are the briefer bursts shown in the EMG channels of this polysomnogram. Largely, the technique is to either bin this activity by 3 seconds, so-called mini epochs in a 30-second epoch, and if there's a little burst in it, you count it as positive. If the epoch is negative, this would be an example for a negative one in the chin channel here. You would count that as a negative epoch. And then you can simply perform a calculation of present muscle activity over REM sleep time. And the great problem in trying to do this is trying to delineate muscle artifacts, which is related to arousal or sleep apnea events during REM sleep. And as you might imagine, those of you who do sleep work or neurophysiology can know this type of activity visually and qualitatively can be a bit of a dark art, but there are rigorous methods, ours and others, meant to look at the amplitude and duration of this activity and measure it. So again, without getting too far into the weeds, that's the shorthand version of how we measure phasic, tonic, and the parsimonious term any muscle activity. I like this one. The any muscle activity means phasic, tonic, or both when they're overlapping. And this is quite a nice way to try to tabulate this activity that's often quite complex. Um, this is data from a recent study we did published in the Journal of Clinical Sleep Medicine last year. But if you quantify this activity, you can develop ROC determined diagnostic thresholds for how much activity may be diagnostic of REM sleep behavior disorder in a case control fashion. So these various numbers shown here are meant to depict that for various individual muscle channels, muscle combinations in an automated method. And if any sleep people are in the audience, the number one question I get is how much is too much? My answer to that these days is if you look at a combination of the chin and arm channels, about 15% abnormal muscle activity throughout REM sleep appears to be a good, reliable threshold. And if you look across all the channels, including the legs too, that inflates to about 25% abnormal muscle activity during REM sleep. But anyway, if you plot this out in an ROC type analysis, you can see box plotting the data. RBD patients separate quite nicely and obviously from controls, and you can begin to delineate thresholds that kind of help you diagnose the condition. But we can use it also for other purposes. And some of the areas of interest for research biomarker qualities of RISWA or REM sleep without atonia include what about it as an isolated state when the patient doesn't have a clinical disorder of RBD yet, at least. And there have been some interesting studies of this type, both from our group and others. One from Innsbruck, Austria, in a small cohort showed that when these patients are followed over time, there's an enriched conversion rate for people who develop RBD as compared to the average population basis. About 7 to 14% develop RBD over time versus 1 to 2% in the community, and about 70% have a neurodegenerative marker present at diagnosis. We've looked at RISWA or REM sleep without atonia in patients with and without RBD and found it to be a synucleinopathy phenotyping measure. It helps to delineate patients who may have a synucleinopathy versus, say, a tauopathy underlying pathology and cognitive and motor syndromes. In the setting of isolated RBD, REM sleep without atonia amounts have predicted conversion interacting with age to Parkinsonism. It's been shown to really track more with a malignant phenotype of RBD patients and to also correlate with other markers such as dopamine transporter uptake. And then in the setting of Parkinson's disease-related RBD, interestingly, REM sleep without atonia is seen more in Parkinsonism than essential tremor. I would not want to use a polysomnogram to delineate the two, but when you do, perhaps unsurprisingly, the PD group has more RISWA than the ET group. And again, like an isolated RBD, in PD populations, the REM sleep without atonia predicts a more malignant phenotype and characteristics such as greater Hanen-Yar severity, greater symmetrical akinetic rigid syndrome versus tremor dominant disease, and greater gait freezing, to name a few more malignant characteristics of Parkinsonism. So to show you some of this data quite quickly, because I want to make sure we reserve enough time at the end for questions, if we box plot this amount of quantitative RISWA, and this is the any metric from just the chin in this example, you can see across a large cohort of both cognitive and motor syndromes, be they Alzheimer's disease, cortical basal syndrome, frontotemporal dementia, progressive supranuclear palsy as tauopathies, let's call them, versus Lewy body diseases in MSA, the synucleinopathy groups have a much greater amount of REM sleep without atonia. So again, I wouldn't claim the sleep study can lead to an accurate diagnosis of these patient phenotypes alone, but it can be a helpful adjunct to diagnosis in certain settings. If we look at Parkinson's disease versus essential tremor patient populations, we see that the PD patient group has greater REM sleep without atonia than the ET group, at least when studied in the chin. The leg is actually less specific, and even in normals, we see a lot more of this RISWA activity in the leg than we do elsewhere. When we look at an isolated RBD population at polysomnogram diagnosis, the amount of REM sleep without atonia is an independent predictor for phenoconversion at a certain threshold. We found the level of 45% muscle activity throughout REM sleep in the chin combined with the leg to really help differentiate those at conversion risk versus those at lesser risk. And some questions now come up as to what about the levels of isolated REM sleep without atonia? What is this entity and what does it mean? And can we study it at scale? So we and others have started to look at this, and of course, to define what isolated REM sleep without atonia may be, we need normative data. And so we have looked at least a convenient sample of nearly 120 adults through the lifespan, looking at exactly the same measurements we look at in an RBD diagnosis, and found that the amount of REM sleep without atonia is greatest in older men. So this kind of mirrors the neurobiology of synucleinopathy, which is interesting. We obviously did not have other markers of disease in these patients sampled from our sleep lab. But when we applied various thresholds, looking at either the amount of RBD, the amount of RISWA diagnostic for RBD, we found 14% of this cohort had that degree of elevation of RISWA. When we applied the lens of a 95th percentile percentage of activity, we both could draw thresholds of patients who had that much activity or more, and found that 25 to 32% of the cohort exceeded the 95th centiles for either their age strata or for the overall cohort. So work like this, I think, can begin to define and help us understand what's out there before RBD and potentially help us understand what might be prodromal RBD. Our colleagues in Innsbruck have looked at this, as I alluded to, some years ago now, and found that in a small cohort of these patients followed longitudinally, that there was enrichment for development of RBD, 7 to 14% developed RBD in this cohort versus 1 to 2% in the community. 70% had one or more neurodegenerative markers, meaning things like an abnormal motor test, orthostatic hypotension, or smell loss. And interestingly, they did demonstrate in all these patients a progressive abnormality of RISWA over time. So it does behave like a neurodegenerative process, or at least one that progressively worsens over age and time. So I think we can begin to consider this whole area of REM sleep without atonia on a hypothetical continuum between normal REM sleep atonia and clear pathologic RBD. I think there are a lot of intermediate states in between that still deserve attention. In children and teenage and young populations, they're still developing REM sleep atonia, and these networks probably develop in the normal state up to about age 20 or beyond, as people myelinate the long tracks. So, you know, the tone during REM sleep in the young looks different, and there's a lot of work left to be done in this area. As we shift to the right towards the progressive continuum of greater RISWA, we find that association with SSRI and antidepressants may drive increases in muscle activity. We can see phenotypes of patients with isolated RISWA and segregate them from normative populations. And then we might see something that is being called prodromal RBD. These are patients who might have a few funny muscle jerks during REM sleep, but not enough to call it dream enactment. And their REM sleep muscle activity, unsurprisingly, is greater than the other groups. So this is a work in progress, and I want you to understand this is more of a hypothetical continuum model rather than something well proven. But I think this is where the field may be headed, at least in terms of understanding what comes before RBD. So, to study larger populations at scale, what we're finding is that with this very intensive kind of qualitative hand scoring of polysomnograms, that there just isn't scale to do this. It's too expensive, it's too time consuming, and we need tools that can both automate the process of identifying this activity and that we can also send home with the patient to study them in the field. And here I show data gathered from one such device, the sleep profiler, which is made by a company called Advanced Brain Monitoring. I want to again clarify, I hold no stock or consultancies with this group, but we've collaborated with them through an NIH Small Business Grant Award and really been building towards understanding home sleep validation for RBD for many years. And you can see that this headband type device also has the ability to plug in a chin EMG, even an arm EMG, and that when we've done so with blinded analysis versus a concomitant polysomnogram, the correlation is quite strong and kappa agreement between visual scoring on the sleep profiler device and the polysomnogram is reasonably strong. It's not perfect, but pretty good. When we look at the home sleep profiler recordings between cases and controls, we actually find very nice and similar diagnostic thresholds to what we're seeing in the laboratory with greater elevations in chin and arm and combined chin and arm versus the controls. Again, interestingly, about a 13% level in the chin and arms, sub-threshold below the 15% in the lab is seen in controls about 35% as the amount of risk was seen in the combination of the chin and arms at home. And then if we apply exploratory diagnostic thresholds, we find that the RBD patients meet this quite more frequently than do controls. So this is work in progress, still a small cohort and in need of greater validation, but we think in 5 to 10 years, this will look pretty well validated and shift our practice from a laboratory brick and mortar study more to a home study approach. I alluded to other biomarkers, and I've dwelled quite a bit in REM sleep without atonia because that's our lab's research interest, but I'll show you a few others. This is the DAT or dopamine transporter scan, which is able to help us measure in vivo nigrostriatal pathways in the basal ganglia circuit. And you can see that a normal patient with normal innervation of the basal ganglia shows a so-called double comma with ioflupline update seen symmetrically in the basal ganglia. And those with an RBD abnormality show loss of that signaling on the DAT scan. And so patients who demonstrate this type of loss, both qualitatively and quantitatively, have a much greater enriched risk personally to develop a synucleinopathy over time. And of course, what we want to aim towards ultimately is an integrative model. So it's what we're working toward in NAPS, trying to use multimodality evaluation of these patients across neurophysiologic tests, imaging tests, clinical markers, et cetera. And our colleague Michael Sommerauer in Cologne, Germany, and his group did this very interesting study and segregated patients into a more malignant or late onset aggressive, older aged strata of patients, a cluster of patients with a late onset aggressive course, and a patient group that looked more early onset and benign. So when you use these markers, you can also begin to tease them apart in terms of the disease course. And the later onset group was found to have greater non-motor symptom and sign burden, greater cognitive decline and mood disturbance, greater RISWA, and greater awake EEG slowing. And perhaps most impressively, when this was mapped to voxel-based morphometry on structural brain MRI, looking at brain volumes, you can see these blue areas, which really separated areas of volume loss that mirror what we may expect to see in Lewy body disease. That being that the more malignant group had greater volume loss in these structures than did the benign group in controls. So I think studies like this, increasingly from European large cooperative data sets from the NAPS study and others, are going to be necessary to really kind of unpack the course of this disease in large patient groups. Then I alluded to pathology, and there's, of course, two ways to measure this: at autopsy, the traditional way, and it's been found both that in RBD converters and RBD at the end of life, and those with dementia and Parkinsonism, 94% have an underlying synucleinopathy. When we've had rare examples of isolated RBD patients who died at that disease stage, Lewy body pathology has been described in the brainstem and the pons and medulla, neighboring the subceruleus nucleus structure and the pedunculopontine nuclei. And I can tell you about some unpublished data that we're hoping to have published soon, but we've now seen a truly idiopathic group, at least at autopsy, of patients with no specific neuropathology, but with polysomnogram proven RBD. So I don't know if we need to resurrect the term of idiopathic RBD or truly idiopathic yet, based on a small case series, but at least as proof of concept that that is out there and not every patient has a synucleinopathy. Now, increasingly, we're extending the ability to measure pathology to living patients. The ability to look at in vivo phosphorylated alpha-synuclein pathology has been described in various peripheral tissues as well as the cerebrospinal fluid. And this study from Alex Aranzo in Barcelona is really quite an interesting and powerful one. And what Dr. Aranzo and colleagues did was looked at a cohort of RBD patients and controls and measured CSF alpha-synuclein phosphorylated alpha-synuclein pathology by the RT-QuIC assay, and found that this was a very powerful independent predictor for phenoconversion in the RBD group. Well, a few words about the other not so isolated RBD causes, and there are others, especially in younger patient populations. And if we think of the differential diagnosis of this disorder, first we have to think more broadly of other nocturnal events and things that might mimic RBD roughly, but usually on clinical grounds, especially for an experienced sleep neurologist or clinician. The diagnosis emerges as fairly clear-cut based on the clinical evaluation and the polysomnogram. And this includes things like the non-REM parasomnias, which are disorders of arousal during non-REM sleep. This includes a spectrum of behaviors that may include sleepwalking, sleep tears in children, or events called confusional arousals that can look a lot like a focal impaired awareness seizure. So the polysomnogram is rarely necessary to delineate that from an epilepsy or from RBD, but sometimes is a helpful adjunct. Of course, sleep-related epilepsy might be one mimic, especially extratemporal frontal seizures. I've had some patients, both patients and providers ask me what the initial video I showed was that possibly a so-called hypermotor, in the Cleveland terminology, seizure, extratemporal frontal lobe onset seizure perhaps. And of course, we expect with sleep-related epilepsies the feature of stereotypy, one seizure looking almost identical to the next. And even with scalp negative EEG, that clinical feature, some other clinical features can help us differentiate those patients. And of course, the EEG itself is quite valuable in that distinction. Some sleep-related movement disorders, as well as untreated sleep apnea, can also mimic RBD, both in terms of dream imitation and clinical behaviors. So those are important points of exclusion as well in the sleep laboratory. Now, what about younger patients? And in younger adult populations, there is a more heterogeneous group of other causes. And this can include the strong association with antidepressant use and what has been called by some psychiatric RBD. It includes also synucleinopathy. A few of these younger patients do have an underlying synucleinopathy or at risk for it, but also narcolepsy, autoimmunity, and brain lesions in the pons and medulla. So let's just consider a few of those categories. And particularly narcolepsy, and especially type 1 narcolepsy, which has been shown to be a critical deficiency of the neurotransmitter hypocretin or orexin, which can now be measured in the CSF. But between 15% and a third of these patients might show RBD or at least risk characteristics. And it can be the presenting manifestation, that is, RBD can present first in children with narcolepsy. So, just an important thing to be aware of, that even though we don't usually see RBD in kids or very young, sometimes it can be a feature suggestive of narcolepsy. I mentioned autoimmunity, and I think it's always important if you see a patient with RBD who also has a syndromic presentation. And by that I mean presenting with a diversity of not only other sleep disturbances, such as prominent insomnia or hypersomnolence, but also cognitive, motor, or autonomic dysfunction symptoms or signs at presentation. That is a bit of a rule breaker. And while it can still be a synucleinopathy, many times these patients are found to have autoimmune markers specific for autoimmune encephalitis. And a few of the disorders that have been most strongly linked include the IGLON5 autoimmunity syndrome, anti-MATA, and the broad spectrum of previously called voltage-gated potassium channel antibodies for LGI1, Caspr2, and DPPX. Keep that in mind, because this is a highly treatable condition with immunotherapy in most cases, and also suggests that the patient may need screening for paraneoplastic syndromes and an underlying malignancy. Brain lesions, both in or outside the setting of autoimmune encephalitis, can cause RBD. Here's an example showing hyperintense signal in the pons and medulla in such a patient with MS, in this case, so an autoimmune condition, but not an autoimmune encephalitis, but a plaque just in the right spot to cause a RBD presentation. Well, last, I want to very quickly cover this idea of prognostic counseling. And what, if anything, should we tell patients about this prognostic risk? When we've surveyed patients and asked them themselves what would they want to know, the vast majority, over 90%, do favor receiving some form of prognostic counseling from their sleep medicine provider or neurologist about the link with synucleinopathy. And when we surveyed providers, experts in RBD, most providers offered such counseling, but only about a third asked the patient what they would want to know about this. And I think, since it is a sensitive topic, I think this unveils a bit of a practice gap. And I'm encouraging people to think about this ask, then tell kind of approach. Ask the patient what they may want to know. Most will say, yes, I would like to understand, is there anything else associated with this condition I'm at risk for? And we can begin to separate, I think, without still strong ability to individualize the prognosis. But here are some factors that we now know are kind of proven weighted risk factors in aggregate and on average. That there's likely higher risk in the older patient strata, especially those 65 and up. Those who already have clinical symptoms or signs of hyposmia, cognitive or motor impairments, are also likely at greater risk. What about those who might be privileged to have lesser risk? That would include those with early life onset RBD, particularly below age 50, those on a concomitant antidepressant at presentation, or of course with a proven alternative cause. There's been no evidence that if they have narcolepsy and RBD is part of it, or they have a autoimmune encephalitis, that patient group has a heightened risk for later Lewy body disease. So in conclusion, isolated RBD is common. It affects about 1 to 2% of community dwelling adults. There is a strong association, particularly in older adults, with the synucleinopathies. About 3/4 of those 70 and up will develop MCI, PD, or MSA over time. And younger patients might have heterogeneous other causes that sometimes deserves expanded workup, brain imaging, and measurement of autoimmune titers or consideration of other causes. Some of the prognostic markers we've reviewed, but include clinical markers, REM sleep without atonia, in vivo alpha-synuclein pathology in the DAT scan. And I believe or contend that RBD patients really merit some prognostic counseling at presentation. Ask them what they want to know before telling, I think, importantly, but approach this whole area with shared decision making with your patient. And I'd just like to briefly acknowledge those in our lab program, as well as internal and external collaborators. My mentors, Brad Beauvais and Mike Silber, who have taught me a ton about this in the last 25 years, and our NAPS consortium, which makes all things RBD possible. If you have potential patients who'd be willing to share, please consider referral to our study, which is ongoing. And I thank you very much for your attention. If you have other questions that we run out of time for, please contact me at the aforementioned emails. And I do want at long last to get to the all-important CME credit-seeking slide. So it appears that today's not so acronymic code is MOLU, MOHLUW. And that should be texted to the number shown. Thanks again to Ms. Woods, who could probably answer more detailed questions or help troubleshoot that. But again, if there are questions, please seek me out. And thank you very much for your attention and for having me today. It's an honor.
Thank you, Dr. St. Louis. So this is a very helpful talk and gets us thinking earlier and earlier about what's going on with our patients. We have a question in the chat. Are there any factors that accelerate phenoconversion? For example, genetic, environmental, stress, physical, or mental?
Aside from the aggregate information I presented about various markers, there's not been, to my knowledge, any genetic markers to really convincingly show this yet, at least in large populations. You might wonder about that. But interestingly, we found some isolated genetic syndromes in older adults, particularly GBA patients, where, it seems to be a slow burn. And these patients are already in their late 50s, 60s, early 70s with no other obvious disease in their RBD. So, yeah, I'm not sure genetics will prove to be one. I think a lot of factors need to be teased out with what are the mechanisms of aging despite aging, and some of the candidates there are senescent cells, neuroinflammation, so-called, a variety of things that we just don't understand very well yet that need to be teased out. So I think the next decade will really need to try to look at this mechanism of the connection with aging in much richer detail.
Well, the next question has to do with night-to-night variability. How many nights sleep do you need to record with a sleep study to capture RBD?
It's a great question. There's precious little data of this type, contrary to conditions like sleep apnea. So I think there's a room for a lot more research in this area. One of the few studies that looked at this was from France. Isabelle Arnulf at the Salpêtrière in France looked at this many years ago now and really showed that phasic muscle activity can be quite variable night to night. Tonic muscle activity, if it's present, and it often is not, especially at onset of diagnosis, is much less variable and more of a fixed finding. I'd say that's what we know about it so far. We do rarely repeat a polysomnogram, but usually it's when we miss recording REM sleep. And I would say that even with a few REM sleep periods, it's usually sufficient for diagnosis in a single night. For example, our lab and other studies that quantify this activity for research accept as a minimum threshold for the amount of REM sleep a 5-minute period of analyzable REM sleep. So I think if you have at least that much, your ability to make a diagnostic assessment is, let's say, pretty good, if not perfect. We will learn, I think, a lot more about that night-to-night variability, especially in the home study, once we can deploy home measures at scale and say study patients for a week and study this activity with an automated method. So wait for it. I think that data will come, but it's not here in abundance at this time.
So I have a question for you. Do you have information about those patients who would be in favor of receiving prognostic information? Do you have information about how many of those were glad that they got the information after the fact? Or satisfied?
Yeah, it's a great question. We asked something a little bit like that in our, is there buyer's regret? And, it does seem that a smaller proportion of patients, you do worry about harms of this type of counseling and needlessly worrying patients about an unactionable condition that might be a slow burn and might not progress for many, many years. So I think it was something like only 10% of our patients said they would not want to know about their prognostic risk. And most patients, well, we didn't ask, were you glad about it? We did ask, the question, would you like more or less information in retrospect? And it was something close to 90% also said that they wanted even more information than they had already received. So, and another somewhat smaller proportion, about 2/3, that sought information on the internet. So, I think there is an appetite for this information on aggregate, but always a good idea to try to avoid harms. I think patients with real significant mental health comorbidity might also be another risk group that you worry about the harms, and maybe hold off on that information until providing that information at the onset of the visit, and try to, meet back with them serially and get into that later.
All right, any further questions? I don't see any.
I do have a quick question, actually. So with RBD starting at a younger age, autoimmune encephalitis is one of the thoughts we have. But overall, when do you consider, other than age, obtaining an autoimmune workup for patients with RBD?
We have found it in older adults too. So I think the kind of diagnostic synchronon of those patient types is typically, not always, but typically a more subacute evolution of symptoms and a syndromic presentation, by which I mean concurrent, prominent, cognitive, motor, autonomic, or other sleep disturbances. One of the classic ones described years ago now is Morvan's syndrome. And that really is an unholy trinity of insomnia, RBD or parasomnia, and often peripheral nerve hyperexcitability, as well as CNS hyperexcitability, sometimes with epileptic seizures. So that may be a classic phenotype, but sort of variants on that theme. If you want to read just one paper about this to show the kind of pleiotropic heterogeneous symptoms that can be seen, look at the Spanish work with the IGLON5 autoimmunity syndrome, or our Mayo series, because it's really all over the place. But the hallmark is most isolated RBD doesn't have a lot else than just the RBD at onset. And if they have real prominent insomnia, hypersomnia, other parasomnias with overlap parasomnia and sleepwalking, plus cognitive, motor, or autonomic stuff from inception, worry about autoimmunity.
Thank you.
All right, great having you with us, Dr. St. Louis, and thank you for your talk.
Thank you, Perry. Thank you, Mohammed. Thank you, everyone.
Thank you so
all the
much.
best to you out there, to our friends on the East Coast. Take care.
Thank you. Bye-bye.
Have a good week. Bye-bye.